Hello, everyone, and welcome to the Alberta Transplant Institute. We're very excited today to have as our speaker, Dr. Beatriz Dominguez-Gil, who is a nephrologist located in Spain. She's known to many of us for her amazing work over the years, especially in terms of the well-renowned Spanish organizational structure for organ donation and transplantation. So Beatriz joined the Organización Nacional de Trasplantes, or ONT, in November of 2006 and became its Director General in 2017. As many of you know, the ONT is acknowledged worldwide for the development of the Spanish model in organ donation and transplantation, which has led Spain to extraordinary levels of deceased donation and transplantation over the years. ONT undertakes a number of very creative programs nationally, aiming at increasing the availability of human organs, tissues, and cells, and ensuring high quality and safety standards, and also importantly, promoting best practices in the field. And the ONT certainly has a robust program for international collaboration through different organizations and bilateral agreements that have been established with a number of countries. And we've been very pleased to work with her closely from Canada as well. Beatriz is the immediate past chair of the Committee of Transplantation of the Council of Europe, president of the Ibo-American Network on Organ Donation and Transplantation, and a member of the World Health Organization Task Force to promote ethical practices in donation and transplantation. She's past chair of the European Donation and Transplant Coordination Organization, and also one of the past counselors of the Transplantation Society and a member of its ethics community. And it gives me great pleasure, to welcome Beatriz. We've spoken and met many times over the years, and I think she's going to have a lot of interesting things to share with us here as she tells us about this experience over the years, where it's come from and how it's grown. So Beatriz, welcome, welcome in virtual sense to Alberta.
Thank you for your kind introduction, Lori, and it's a pleasure to share a short time with you. But I think it is going to be very interesting, particularly the discussions that we may have. So I have tried to prepare a summary for you of some of the elements that I consider it might be more interesting to learn about the work we have performed in Spain over the last few years. So starting from the very beginning, these are data from the Global Observatory on Donation and Transplantation, where you can see how in 2019, there were close to 154,000 solid organ transplants carried out in the world, an impressive activity that we know barely covers, according to WHO estimates, 10% of the global transplant needs. And very importantly, you can see how according to the, According to the observatory, we also estimate that there has been approximately an 18% decline in global transplantation activities in 2020 as a result of the COVID-19 pandemic. So it is very likely that this disparity between supply and demand has been exacerbated during the COVID-19 pandemic. So within this framework, there are two important principles that have been guiding our practice in Spain over the years. This is, in the very first place, the Madrid Resolution, which was a product of WHO Global Consultation in Transplantation held in Madrid in 2010, by which countries were called to pursue self-sufficiency in transplantation. We were called to decrease the burden of diseases treatable with transplantation on one hand, but also to increase the availability of organs. And the WHO in this resolution was very clear that priority should be given to donation from deceased persons, and donation made possible whether death was declared by neurological or by circulatory criteria. So to us, a very important principle is that we should be developing disease donation to its maximum therapeutic potential while ensuring the protection of the live organ donor. And a second very important principle that I think is well underpinned in Canada as well is the fact that decision-making at the end of life is not only based on medical aspects, but also should be based on moral, societal, and welfare considerations. This is well accepted in our country, and we have within this framework a number of national documents released by the relevant critical care societies that promote the principle that donation should be a routine component of end-of-life care, which means that whenever a person dies or is about to die in conditions consistent with organ donation, this should be offered as an option, and everything should be done to facilitate organ donation if this is consistent with the wishes and the values of the individual. So we believe these two principles have been critical in the development of disease donation in our country. So this graph shows in columns the number of actual deceased organ donors over the years, and the circles show the rate of deceased donors per million population. And you can see here how we have 4 different phases in the evolution of disease donation in Spain. So we have a first period of time in which ONT was created as an agency depending on the Ministry of Health of the country, which is important because it placed donation and transplantation in the political agenda. The government was responsible and was accountable for the practice of donation and transplantation. And we had to work and were responsible for organizing, coordinating the activities in a country which had already a good transplant law that was issued in 1979. We had good technical capacity for the practice of transplantation. We had a public healthcare system of a universal coverage. And as you have in Canada, we had the political competences transferred to 17 different regions. So ONT agreed a model of coordination with the 17 regions that led our country rapidly evolve in this first phase from 14 to more than 30 donors per million inhabitants in a short period of time. Then we have a second phase where you can see how disease donation is very stable. It's an apparent stability because it occurs in coincidence with a decline in the pool of DVD donors. We have a third period in which disease donation is able to be increased further. So we achieved our record, our historical record in 2019 with almost 50 donors per million inhabitants. And this period responds to the implementation of a set of novel strategies. And then, as everyone, we had COVID. And we are now struggling with recovering what we had achieved over the last few years. So in my presentation, I'm going to focus on the pillars of the Spanish system very briefly, and I want to expand a little bit on what we did over this third period of time, and on over the discussion, if you wish, we can talk about COVID-19 effects. Although I'm a little bit bored of talking about COVID, if I may admit. So in order to locate Spain in the globe, here you can see 2019 data. It is 49 donors per million inhabitants. We had really a privileged position compared to the majority of countries throughout the world. This has been the impact upon transplantation. So if in 1989, we were performing about 1,300 transplants, you can see how in 2019 in particular, we were able to almost reach 5,500 transplants in a year. And compared to other regions across the world, you can see how along with the US, we've been able to achieve very high levels of transplantation, with the difference with the US that most of our transplants, 90% of our transplants, derive from deceased organ donors. So if we're going to talk about the Spanish system, I think it's important to dismantle the myth of the presumed consent policy. And I think this is important because I'm aware that in Canada, you're currently discussing about the possibility of deemed consent. We do have an opt-out system in Spain, a presumed consent policy, since our legislation was issued in 1979. And we believe there are very positive things about having this policy, because the message that is transferred to the population is that the normal thing to do in a country where there is universal access to transplantation is to donate organs. But we have always thought that strictly applying the presumed consent policy could be very negative, because the population could perceive the state as the owner of the organs. without taking into account the views of grieving families. So the procedure that we follow is detailed in secondary legislation. The coordinator must check, among others, the advanced directives registry, where every individual can record whether their decision about organ donation, whether positive or negative. With that information, coordinators approach the relatives, and of course, they try to reach a consensus, taking into account where they think were the values, the principles, and whether donation were consistent with those of the dying patient. And they try to reach this agreement, but of course, if the family says no, they have the final word, and we don't proceed with organ recovery. So you can see how in practice, though, we have this regulatory framework consistent with our presumed consent policy, we don't apply it strictly. So we don't consider the high disease donation rates achieved in Spain are attributable to this opt-out system. If we had to summarize the first period of the Spanish model, we would use the word organization or management of a process of high complexity and multidisciplinary process, which is the process of donation after death. Here you have the DBD pathway. We keep representing the DCD pathway, but we know that of all these different phases of the process of the pathway, the most critical one is that of identifying persons who die or are about to die in conditions consistent with organ donation. So we have conceived a system to systematically identify these exceptional circumstances of death and ensure their transition to actual and utilized organ donors. These are the elements of the Spanish model that have been very well described in the literature. In the interest of time, I'm just going to focus upon three elements. The first one is that we have placed the intensivists in the midst of this process. Intensivists are the ones who are going to be orchestrating the disease donation pathway. So for you to have an idea, we have 185 hospitals that are authorized for organ donation in the country. And according to the legislation, they must have an in-house donor transplant coordination unit. These units, which, as I said, are located within the hospital, are composed in 63% of cases by physicians and 37% of our coordinators are nurses. But among physicians, you can see how more than 80% are intensive care doctors. So this means that our teams are led, are managed by physicians from critical care, which have who are part-time dedicated to the activity in most instances, and that have created very good links with their colleagues in ensuring donation is a routine option considered at the end of life, and in order to propel and identify different strategies to make this donation a successful activity. We have also created a system to coordinate coordinators. This system is composed on one hand of ONT at a national level, depending on the Ministry of Health, and the regional level, the regional coordination officers, which depend on the regional health authorities. And between the national and the regional level, perfectly coordinated through a national transplant committee, we provide support to the development of disease donation in the hospital by designating coordinators with the appropriate profile, by ensuring continuous training and education, providing protocols, guidance, recommendations, and continuously evaluating performance through a potential donor audit. Remember the Hawthorne effect. Everyone who feels observed automatically changes their behavior. So we need data, and data very precise to understand what happens within the hospital in the disease donation pathway to identify areas for improvement. And training has been an essential component of the system. We use every year governmental funds. We make a call for proposals in different institutions and different organizations provide training, not only to coordinators, but intensive care, emergency care professionals, non-healthcare professionals like the media, the judges, and they provide that training based on the strategic lines that have been identified by ONT. It's important to say that many of the elements that I have shared with you have been replicated by other countries totally or partially, with great success. And I would like to acknowledge the effort that, for example, Canada has made in incorporating the intensive care community in the process of disease donation by designating donation physicians who are very similar, though not identical in their responsibilities to the physicians who are inserted into our in-house donor coordination teams. But you can see how, in fact, Canada has been able to increase disease donation over the years. I know that COVID has also had an impact upon the transplantation activity in Canada, but these elements have been also reproduced in Australia, in the United Kingdom, or in the United Union as a whole with good results. And we are particularly proud of what has happened in the Ibero-American region, with which we've been cooperating since 2005, advising governments and providing training to professionals from the Latin American region. Particularly, we are training professionals in Spanish hospitals as donor coordinators for periods of 2 months since 2005. We've been able to train more than 450 professionals in this way, and the region has been able to double this donation from 2005 to 2019. But if we now go to the third period in which we were able, of our evolution, in which we were able to further increase this donation, we would use the word innovation. And we were forced to innovate because the situation in Spain was changing profoundly, and we were working in an environment that made donation a little bit more difficult than it used to be in the past. For example, the incidence of brain death has been steadily declining since the beginning of the century, but you can see how it is stabilized over the last few years in about 50 cases per million population. The decline in the incidence of brain death is associated with a decline in events leading to devastating brain injury and improvements and changes in neurocritical care. For example, now the use of decompressive craniectomy is very, very frequent, as it will be in Canada, I guess. And there have been also very important changes in end-of-life care. So we are aware that many of our patients who die as a result of a devastating brain injury in Spanish ICUs, at present 40% of them die following the decision to withdraw life-sustaining therapy because this is no longer deemed beneficial to the patient. On the other hand, our possible organ donors are becoming older and older and older. So their median age at present is 63 years. You can see here how the interquartile range is 50 to 73. So it means that 25% of our possible organ donors are over 73 years of age. Most of them die because of cerebrovascular accidents. We have also 23% cases who die as a result of anoxic encephalopathy. But when we revise the mechanism of death, these are in most cases natural deaths. So for example, in Spain, it is exceptional to have a possible organ donor who has died as a result of a drug overdose, which is becoming an issue in North America. But in Spain, fortunately, we're not having these persons dying as a result of a drug overdose. We so far don't have such a problem in Spain and in most of South Europe, I would say. So our donors are becoming less frequent, and they are becoming older and with greater comorbidity. So we definitely had to change the way of acting, or otherwise we were not going to be able to cope with the transplantation needs of our patients. So along the years, we have been developing different strategic plans in order to keep increasing organ availability. We are now in the midst of the so-called 50-22 plan, which intends to reach 50 donors per million inhabitants by 2022. We would have reached this in 2020 if COVID-19 had not come to visit us, but still we are now trying to recover the activity and the impact of COVID and reassuming all these strategic lines. Of all these lines, I'm just going to mention 3 of them, but we can discuss about the rest if you wish afterwards. So first of all, you made the views that we needed to use organs from old and very old donors. So here you have the evolution of this is donor age in Spain. And although our donors have become a little bit younger in 2020 because we were forced to be a little bit more selective, you can see how in 2020, more than 50% of our donors were over the age of 60 years. Almost 30% were over the age of 70 years, and 5% of our donors were octogenarian. So we had been forced to use organs from these donors because this is the type of potential donors that we have. And we mostly are using and following an old-for-old allocation strategy. If you take a look to this is donors per million population comparing international activity, and you see here in this light blue donors over the age of 60, you can clearly see how the differences between Spain and the rest of the countries mostly lie on the consideration of organ donation from donors who are old or very old. So this is the most relevant difference between Spain and other countries in terms of disease donation. Of course, you will tell me that organs from old donors do worse than organs from young donors. We all know that. But we don't believe this is the type of comparison that we should be doing. In this study, we compared the risk of death of recipients of kidneys, recipients over the age of 60 years who had received a kidney from a donor over the age of 60 years. And we compared the risk of death with that of their counterparts who remained on the waiting list. And at 12 months after transplantation, the risk of death was significantly lower for recipients of old kidneys compared to those who remained on the waiting list. And this significantly lower relative risk of death was so whether the donor was between 60 and 80 years or whether the donor was 80 years or older. So we believe that sort of comparison that we should be doing when considering the utilization of organs from all donors is with the evolution of those who would not get a transplant or who would be remaining on the waiting list or dying. A second important and fundamental element to increase disease donation over that third period that we were observing at the beginning of the presentation was DCD. So in Spain, in light blue, we have been developing and controlled DCD since the 90s. This refers to donation from persons who die following an unsuccessfully resuscitated cardiac arrest, usually occurring in the street. It is a very complex program, as you may imagine, and it has been declining the activity over the last few years because of its complexity, but particularly in 2020, in March 2020, the activity stopped, and we are still struggling to recover this program at the moment where the availability of resources because of the COVID-19 pandemic is decreased. So, but what I think it's very important in this slide is that you take a look to control DCD donors in dark blue. We were a little bit behind Canada in developing controlled DCD. We made our pilot program in 2009 in a specific region of the country, and following this pilot, we developed a regulatory framework that accommodated the practice of controlled DCD in 2012. And you can see how we were able to exponentially increase the number of controlled DCD donors to the point that even in 2020, you can see how we were able to record 13 controlled DCD donors per million population in a very complex year. And right now, 35% of our donors are controlled DCD donors. When we take a look to international comparisons, and I always take in 2019 because 2020 is highly contaminated, you may see how there are 22 countries reporting DCD activities to the Global Observatory. Numerically speaking, the most important program is in China, but many of these DCD donors are what the Chinese call DBCD donors. This means persons who are in a brain death condition and in whom a DCD pathway is activated because of reluctancy to accept death by neurological criteria. Then you have the US, and then we have Spain. So if you take a look to absolute numbers, we are the third in activity, but in terms of DCD donors per million population, we've been able to reach the highest levels of DCD activities in the world in a very short period of time. Very importantly as well, we have been struggling to make DCD, and particularly controlled DCD, a multi-organ recovery procedure. So we are not exclusively using kidneys from DCD donors, but also livers, also lungs, also pancreas. And we initiated the controlled DCD heart transplant program in January 2020. Well, of course, in order to make the program or DCD a multidisciplinary process, we had to confront the reality of poor results that are obtained with DCD organs, particularly livers, and of course hearts compared with DBD. This is our main fear in DCD. This is an explanted DCD graft, liver graft, with multiple intrahepatic abscesses in the context of an ischemic cholangiopathy. So we needed to confront this and ensure appropriate post-transplant outcomes. And in Spain, what we have decided to do is to use what we call normothermic regional perfusions after acquiring large experience in the uncontrolled DCD program. So in NRP, we use an ECMO device to perfuse organs subject to transplantation with oxygenated blood following the determination of death and prior to organ recovery. Here you have in a pig model the macroscopic appearance of the liver and the small bowel after 30 minutes of cardiac arrest and after 30 minutes of normothermic regional perfusion. So you can see macroscopically and visually what we achieve with normothermic regional perfusion. What are the advantages of NRP that has made our country to support the expansion of this perfusion strategy? First, based on basic research, we know that it helps us to regenerate ischemically damaged tissue. It reconditions organs prior to transplantation. It facilitates organ recovery, so organ recovery becomes a little bit closer to a recovery in the DBD setting. It allows us to evaluate organ viability prior to transplantation based on the functioning of the organs and the behavior of some biochemical parameters. It has made in Spain possible DCD heart transplantation without expensive and unaffordable for us excitomachine perfusion devices. And it allows also to simultaneously perfuse several organs. So we also save costs because we don't need excitomachine perfusion for each of the organs that are recovered from a specific donor. So it really has very important advantages. And we have proven that it is really worth it. So this is a very large series of controlled DCD liver transplantation in Spain, in which we compared the outcomes of more than 500 livers obtained with NRP, with 258 recovered with the standard rapid recovery technique, where you can see how already in the univariate analysis, we observed superior patient and graft survival comparing NRP with the standard rapid recovery technique. And when we performed a propensity score matching model, we observed that NRP significantly decreases the risk of early allograft dysfunction, hepatic artery thrombosis, biliary complications, including ITBL. It decreases significantly the risk of retransplantation, graft loss, and patient death. But besides, in the field of kidney transplantation, we have also published our experience with more than 1,400 kidneys from controlled DCD donors recovered with the standard rapid recovery technique versus 865 with NRP. In the univariate analysis, we couldn't see significant differences between the two, but in the propensity score matching, and here the reference is normothermic regional perfusion, the rapid recovery of kidneys was associated with a significantly higher risk of delayed graft function defined by the need for dialysis in the first week after transplantation, and a significantly higher risk of graft loss during the first year. So we have observed advantages in liver and in kidney transplantation, to the point that we are expanding donor criteria and controlled DCD transplantation. And right now, the profile of the controlled DCD donor is becoming closer and closer to the profile of the DVD donor. And as I said before, this study has been critical for us to be able to develop heart transplantation from DCD donors. So we use thoracoabdominal normothermic regional perfusion following the first cases described by the Cambridge group, the Papworth Hospital. Of course, this means that we need to cross-clamp the supraortic vessels, and following the Canadian and British paper, we are also deviating using cannula over the clamping in order to divert any collateral perfusion or possible collateral perfusion. And the heart, after recovery, is placed into cold storage without excitomachine perfusion. We initiated the program in 2020 in a very bad year, but still we've been able to perform 15 procedures of this kind by 8 different centers. So the fact that we have more than 120 centers with a DCD program, you will see how we have managed to have NRP available in most of the hospitals. So this allows us to have the possibility of developing heart transplantation from DCD donors with normothermic regional perfusion in a variety of places across the country. So we really believe with this, we are going to be able to further expand heart transplantation in the country. This is what I wanted to show you. Here you can see how if in 2007, 40% of DCD donors were subject to normothermic regional perfusion. Right now, it's more than 70%. And in many cases, in dark blue, we're using portable devices. So we have teams located in one hospital who will be moving or going to hospitals without the resources or the capability to support them to develop DCD with a normothermic regional perfusion approach. The other element that I wanted to talk about, although I think you may have even more experience than Spain, but just in case, has been the experience of DCD with capable persons who are able to consent to posthumous donation when death is becoming evidently close and imminent. This is the case of patients with some neurodegenerative diseases like ALS. So we started this program for patients who at a given moment did not accept to receive ventilatory support any longer or rejected to continue with it, and they were subject to sedative and terminal sedation. We initiated this program in 2013. We're in the midst of developing a national protocol, but you can see how since then we have had 124 donors with diagnosed with ALS, most of them controlled DCD donors, 310 transplants. And importantly, because there have been doubts on whether this is a disease that may be transmissible through transplantation, as for any donor which raises doubts about transmissible diseases, we have a program which is called the Non-Standard Risk Donor Project, in which we prospectively follow all recipients of organs from donors with specific diseases and conditions. And we have made a prospective follow-up of all these recipients, and we haven't observed or described any event that could be considered associated with the disease in the donor. And finally, I'm not very sure you're aware that MAID, euthanasia, was approved in Spain, was regulated in Spain in June 2021. It has been approved as a service of the healthcare system, so it's considered a right of the patient. And when this was approved, we were sure there would be patients that wanted to be organ donors as well. So we provided certain recommendations to the donor transplant coordination teams. We are now finalizing a national protocol. We were very well aware of particularly the experience in Canada, and you have served as an inspiration to us. And so far, and take into account that the law entered into force in June 2021, we have had 5 cases of donation after MAID. So I think this is going to be also very importantly contributing to increase organ donation and to give these patients with so many difficult decisions at the end of their lives to be donors, if that is consistent with their values. And to realize, I'm just going to give you the practice that we call intensive. Donation to be possible. This is not a new practice in Spain. It's not a new practice in different countries, but we decided to give it a name. A name in which we underline the word care, because to us it's very important not to forget the main and fundamental principle of the dignity and care of the patient who is in the dying process as a paramount and as a paramount principle. But we give it a name with the intention of ensuring transparency in the communication between professionals and in communication with family members when there was a shift from therapeutic interventions, therapeutic intentions towards end-of-life care and facilitating organ donation. So we have been able to perform to develop these documents that provide guidance to professionals. These documents have been produced with the Spanish Society of Emergency Care and with the Spanish Society of Intensive Care about intensive care to facilitate organ donation, which is then considered a good practice by this critical care community. And we have been training thousands of professionals in this practice over the years through the courses that I mentioned to you in the very beginning. So looking at a very complex year as 2020 and based on data from the potential donor audit, you can see how out of 302,000 possible donors in our ICUs, this means patients who died as a result of a devastating brain injury in Spanish ICUs, 13% of them were admitted into the ICU just to enable organ donation. And you can see how many of them transitioned to actual organ donors, and 17% of actual donors derived actually from the practice of ICOD. So ICOD has really contributed to increase organ availability in our country. So to finalize, I think it's important to say that I'm sure that some of the strategies may be challenging to you, and you may consider that many of them are not straightforward, applicable to your reality. But I would like to remind you of this sentence of Albert Einstein, who used to say that insanity is doing the same thing over and over again and expecting different results. So I would like to invite you to think different. Thank you.
Thank you very much, Beatriz. That was a wonderful overview of the amazing progress you've made in Spain over the last while, and also responding to evolving trends in MAID, for example, or evolving trends in especially in your plateau, and then increasing by I think also an outreach, if I remember Rafael Matason's an outreach just specifically into the emergency departments, which was really helpful. We have time for a question and discussion, and we have a few questions already. Murray Wilson asks us, he says, I noticed in two of your charts that there was a goal in 2022 of 50 per million, obviously a pre-COVID target. And his question is, who sets these quantitative goals and targets, and how do intensivists and others in the community, other physicians, react to the quantitative goals and targets?
Well, that's a very interesting question. In fact, we developed the strategic plans. As I told you at the very beginning, our system is structured at the national level with ONT, then we have the regional offices, and then we have the hospitals the hospital network. So what we do is at the national level, I guess this is the way you work in Canada, I ignore it, but because the political competencies are transferred to the regions. So we have this National Transplant Committee, which is chaired by ONT, which is composed of the regional coordinators. And there, And of course, we report to the national healthcare system. They are set our strategic plans and our strategic goals. The goals are usually follow an assessment procedure for which the potential donor audit is absolutely critical, where we can see where areas for improvement are feasible. And we decide these goals at a national level. And in general terms, there is a good reaction towards these challenges, particularly because we were able to show every year that some regions, please take into account that there are differences in mortality, there are differences in hospital mortality as well, but these are not that profound to justify differences across regions. So usually exhibiting the results of hospitals and of regions become a little bit of a challenge, a positive competition, let's say, between centers and regions, and usually they are well accepted. Of course, we need to explain very well where we reach the conclusion of that target, where we do consider this is feasible, what are the measures that we need to implement, but usually they are very well received, but take into account that the intensive care community is with us, which is also critical as well.
Thanks. I think one of the things that comes up, and you've spoken to it here, but it just it is accentuated in my mind, having listened to some of your work before, is that going back to the contribution of the opt-out way that things are structured for consent. Nonetheless, as you've clearly explained, it seems that it's really more the systematic, the system structure and the systematic addressing of many factors into one way of dealing with things that seems to be so effective. Do you want to talk about that a little bit?
Yeah, yes, well, I think having a presumed consent policy, as I said, it makes everybody feel very comfortable because, of course, for example, if you're considering the admission of patients from the emergency department into the ICU to enable organ donation in uncontrolled disease where you need to extend CPR beyond futility. In many situations, having a presumed consent policy from a legal point of view, it gives you, let's say, certain comfort that you are preserving donation opportunities, and you are supposed to do that because you have a presumed consent policy. But I think that's absolutely feasible as well with an opt-in system. I don't think you need a presumed consent model to do so. And as I told you, in real practice, when we look for consent, when we approach relatives, we follow a system that is very similar to the one that you may follow in a country without a presumed consent policy. And I do agree that the key for success here is identification. Of course, you need to be trained for the family approach, for donor management, for logistics, but the key issue is identification. We have possible organ donors everywhere. We don't see them, but they are there. We have those who are already in the ICU, but we have possible organ donors with terminal neurodegenerative, heart, lung diseases, or with devastating brain injury in the emergency department, in palliative care, in internal medicine, in neurology. I mean, you have really everywhere possible organ donors. So you need to organize the system to ensure a proactive identification of cases. You need to train professionals for them to identify and report and notify the coordinator, but the coordinator needs to be proactively identifying these cases. This means that they need to visit all the units every day. They need to train them. They need to provide feedback to these units about, well, do you remember this particular case? This individual became an actual organ donor. This was the result. So they are continuously working in a proactive system of identifying donation opportunities. And to me, that's the essential element. Because if you fail in donor identification, no matter how good you are in donor management or family approach, nothing works.
Very good point. A very good point. We have some more questions here. Many thanks for the great talk. How do you think Canada is standing in taking the initiatives from an international perspective to better implement the needed legislation and ethical practice guidelines for an improved organ donation experience, especially with MAID? An example, Nova Scotia implemented deemed consent for deceased organ donation, which, as I know you know from the work we've done together, is the first jurisdiction in North America that has done that. And I also, know that a question about or comments about Canada as a whole are difficult when our health regions are provincial, mandated by the province. But do you have some comments on that as to how the rest of the world sees that?
Well, I think Canada I think it should be acknowledged by important contributions to the practice of organ donation. Although, for example, Belgium and the Netherlands were ahead of Canada in developing donation after euthanasia. The way you managed to develop the guidelines, and the process of disease donation, how quickly it was implemented and how in a very robust manner, to us it has been an example. I mean, when we saw that the euthanasia was going to be regulated in Spain this year, we saw very clear that we had the technical capacity to do it. We had the ethical justification very clear, and it worked like this. So it was thanks to you and to your experience, your CERT experience, that helped us on this occasion. Regarding deemed consent, well, I mean, I think if you want to make the movement towards deemed consent, received consent, if there is broad consensus, I think it may be worth it. But if there is a tense discussion on it, I think there are many other things to do before engaging in changing the legislation. Mm-hmm. And finally, I would like to thank Canada as well, because of the very important guidelines that has been developing over the years and are very helpful to us. I can think of, for example, of the World Brain Death Project that was very recently published and led by Canadians. I think you make very good practice guidelines that are a good example to everybody. So I think the influence of Canada in this field is really powerful and should be acknowledged.
Thank you. We also have from Linda Powell, how important is a public education and awareness program in Spain in maintaining this culture of donation?
Well, here we have maybe a very specific approach from the very beginning. We were very aware that we couldn't make very effective promotional campaigns. Promotional campaigns are really very expensive and non-effective at all. I mean, we have learned over the years that no promotional campaign has been able to increase disease donation in a sustainable manner. So what we did was to take a very specific approach with the media. We have established a very close alliance with the mass media in Spain. We're always available to them 24 hours a day, 7 days a week. We have specific meetings with them every year. So, for example, last week, we met with all the media during 2 days, in which we were discussing with them novelties in organ donation. We talk about donation after MAID. It was the first time they heard about it. We talk about donation in patients with ALS. We talk about novelties, for example, induction of tolerance. So we devote 2 days to talk to them. So on one hand, we learned of their needs as professionals. How can we help you? How can we be of use to you? And on the other hand, we tell them the importance of what is their responsibility in educating the public. And I can tell you that the responsibility of the media in Spain, after many years of devoting time to them, is so good that when we have a negative news, they call us in advance to contrast the information, to make sure the information is presented in a manner that does not damage the public image of the system. And we continuously help them to get good news and positive news to be spread in the media. We are now dealing with the social media, of course, as well, but we don't invest a lot in promotional campaigns. We really believe that the collaboration with the media has been essential for public education, and it's much more sustainable than other types of measures.
That's really interesting. And so a real targeted education back and forth from the needs to the information. That's a really interesting approach. I don't think I've heard that we've considered that in any of the provinces here. Another question that comes up is what has been the, and maybe this goes along with the previous question, what has been the public reaction to the various changes in practice, including families at the bedside? How have they perceived it each step of the way, you know, when you change things?
Apparently, this is hard, difficult to measure, but in general terms, I would say very positive. And if we want to use an objective measurement, we can talk about consent rates over the years. For example, in the last 5-6 years, where we were introducing all these novelties, consent rates were beyond 85%. And in the DCD pathway, the consent rate is 90%. So we've managed, I think, to spread a good communication. But I am convinced that if professionals are convinced of what they are doing, the population follows. Mm-hmm. So if professionals are comfortable, they are well trained to approach families, the families have confidence in the healthcare system, which is the case in our country. There is a great confidence in the public healthcare system. The population follows, and they are much more advanced than we believe. For example, donation after made, and when we started first to discuss DCD in Spain, we told them, well, we need to withdraw life-sustaining therapies, and the person will die. We will diagnose death. We will start with organ recovery, and people say, why don't you just take the organs? I mean, things that we consider unbelievable, but sometimes, the public thinks we are very afraid of the public, and then the public always is incredible. To us, it always reacts in a very incredible manner. So, for example, with donation after made, it was absolutely natural. It was the patients coming to us to tell us, I want euthanasia, and I want to be an organ donor. So do everything possible for me to be an organ donor. We knew this was going to happen. To us, it has been very good because it was then mandated by the patients. And so it was very logical that we need to react very quickly and to develop a national protocol very quickly. So in general terms, I would say very positive.
Yeah. It's really driven by the patient sometimes. And as you say, the MAID patients are often highly motivated for the outcome that they want. Another question is about pediatrics. Can you describe pediatric practices around organ donation in Spain? Is the NRP approach as widely disseminated in pediatrics? And if not, what do you think prevents that?
Mm-hmm. Mortality in children is fortunately very low in Spain. I guess this would be the case in Canada as well. And it is very robust in the DBD setting, but in controlled disease setting, it has taken us a little bit longer. We, in fact, published our national recommendations on pediatric donation, including controlled DCD, a year ago. With the Pediatric Society and the intensive care pediatricians. And I think it is improving, but I can confirm you that in controlled DCD, the strategy of NRP is the same. The first neonatal heart transplant from a DCD donor was performed with thoracoabdominal NRP. it was transplanted after 4 hours of cold ischemia with a very successful outcome. So right now is what I can tell you. I think we are also evaluating now with the potential donor audit, the practices in pediatric donation, both in the DBD and the controlled DCD setting. It is optimized, but I think we still need to improve certain aspects of the process, I guess, as in everywhere, because we know of the specific challenges of pediatric donation.
Okay, great. And I think we have time for one more question. And for those of you who have put questions in the chat, we will collect those and be sure to follow up on those. But one question that comes up often, Beatriz, is what regarding health economics. Was socioeconomic analysis and cost-effectiveness analysis of organ donation a key component of policy change in your system to develop strong donation systems and supporting patient outcomes?
Absolutely. I think that the health economics arguments in the field of donation and transplantation are sufficiently robust everywhere to make really a change in policy and a change in organization. And well, in our case, the pillars of the system were placed many years ago. But for example, the novel strategies that included certain investment, for example, in ECMO devices, NRP, they are well justified also by cost effectiveness analysis. Sometimes it takes time to acquire the experience, but for example, for the introduction of NRP, I think we have right now absolute, very robust data. We are still struggling with this discussion of not having a randomized controlled trial, but I have to be honest, our professionals in Spain don't want to make a randomized controlled trial, and we struggle internationally with this, but still, I think we have sufficient data and very large cohorts in order to prove the benefits of this strategy. But definitely for certain novelties, the cost effectiveness analysis has been absolutely essential.
Well, thank you so much for touching on all these various aspects of what has contributed to a really amazing success story in Spain, and covering, so many diverse aspects of it that we hear are important. And I think some of those can be adapted to our own provincial systems, perhaps. And it just tells us again how we need to focus on all of those contributing factors and the many players in this field. Thank you so much, Beatriz. I'm just also going to say that for next week, there will be no seminar because of the annual scientific meeting of the Canadian Donation and Transplantation Program, which Patricia is putting in the chat there. The membership is open to everyone. If you're not currently a member, please join us though, and check out the website, which Patricia has put in the registration. Our next seminar will be in 2 weeks on December 15th. And Nick Murphy from Western University will be coming back to similar one aspect of what we've heard about today, and he'll be speaking on controlled organ donation after circulatory determination of death, scoping the ethical terrain. So I think some of those topics that we've heard about today will undoubtedly come up again there. So I'd like to thank everyone for their questions, for their attendance, for their engagement, and especially our speaker for giving us this terrific overview, and also to our support from Paladin, who support the seminar series. Thank you very much, everyone.